Good evening, everyone. Welcome with the webinar of the EAU guidelines on neuro-urology. I have four panel members, including myself here. It's Professor Botulinum, Professor Hamid, and Professor Kessler. They all going to have a very nice presentation on specific topics. Most important topics we're going to speak about is catheterisation, urinary tract infections, and how to handle lower urinary tract symptoms in Parkinson's patients. My name is Dr. Blok. I'm full professor in Rotterdam on neuro-urology, and I give the floor to Professor Hamid. He's going to speak on intermittent self-catheterization, single-use versus reusable catheters. The floor is yours.
Martin, thank you very much for the kind introduction. And ladies and gentlemen, good evening or good morning, good afternoon, wherever you are. It is my pleasure to participate in this webinar on behalf of the EAU Guidelines panel on neuro-urology. My name is Rizwan Hamid, as Bertil outlined. I used to work at the University College London Hospitals and the Spinal Injuries Unit in Stanmore, but now I have moved to sunny Dubai, where I am at the moment enjoying my life. It's quite a nice place, and I will present on the self-intermittent catheterization, single-use versus a reusable catheter. That is my topic. So these are my disclosures. What I would like to do in the next 10-15 minutes is to just get you through that what self-catheterization is about, what is the difference between intermittent catheterization and the reusable catheters, what do the guidelines say and what are the differences between the two, and actually there is any solid evidence behind it. I will try to go through some of the evidence for and against single-use and reusable catheters, and then try to come up with some conclusions. I want to set the scene, and I think all of us are aware that maturation or passing urine is a very private matter. And those of us who have done flow rate on ourselves will actually agree with this fact is that sometimes the flow rate is not as good or bad as it is in private. Hence, if you add that to somebody who needs to catheterize, then it becomes all that complex. One needs to have the familiarity with the catheters. And nowadays, it was previously also true, but all the more that cost and availability is very important. And we're going to discuss some papers from the other panel members looking at these two aspects. And lastly, what is the scientific evidence behind our statements, suggestions, or recommendations? So, intermittent catheterization, briefly, is an act of passing a catheter or a tube into the bladder either to drain the urine or to maintain the patency of the stricture, and can also be used via catheterizable channel like a metrophenol, and the urine is drained. Over the years, no matter what type of catheters, like PVC, the standard ones, the hydrophilic ones, by and large, all the catheters, one way or the other, do cause some problems, starting from infections and castration if it's a permanent catheter. And also there's a difference between intermittent catheterization, which is done in the hospital setting, where it is sterile. That means the gloves, or if it's done by a nurse, is done under a sterile technique, to the community where generally the patient himself or herself does the catheter, which is clean, meaning thereby this might not be sterile. We all are aware that the policy is very dependent from country to country and region to region. Generally, cost and the availability dictates what the settings would be and what type of catheter or what mode, whether single use or reuse, would be used. In spite of the catheter being used all over the world, literally for a number of decades, there's a lack of evidence to support whether there's even between the sterile catheter in the hospital and the clean catheter in the community, whether there's a difference in infection rate. So with that background, why we use the catheters? So intermittent catheters are generally used either for neurogenic patients like sphincter dyssynergia or incomplete emptying, which can be neurogenic or non-neurogenic, or via a catheterizable channel. But there are certain people in which the intermittent catheterization might not be suitable, like poor hand dexterity, insufficient coordination, or where there's a reluctance or inability to perform the techniques themselves or by the caregivers. So with that about the intermittent catheterization, what about the reusable catheters? They are actually more popular than we think they are. Generally, the perception is that these are only used in the developing countries, but there's a lot of evidence that about a third of the catheters in North America, generally the United States, is a reusable catheter, again, going back to the cost and the insurance reimbursement. And the prevalence of increased UTIs with the reusable catheter is conflicting, and that is one of the things which I'm going to discuss in the next 5 odd minutes. Also, there is controversy whether what sort of a cleaning method should be used if one is using reusable catheters. Although there's a lot of studies out there, but when we come to the recommendations by the international organizations, including the EAU, there is a lack of recommendation because there's a lack of solid scientific evidence. And these facts then make it default position in the developed world, either because of the cost, convenience, or medical legal reasons to ask for a single-use catheter to be used as a potential remedy. So we want to look for guidelines. You go to EAU guidelines, which are in our opinion, the best in the world because they are most broad and look at all the scientific evidence. But of course, there's the EAU Incontinence 7th edition, which has just come out, and some of us have contributed to those guidelines. But then we also look at the published literature. Sometimes things are not captured by the guidelines because there's not a high-level evidence, but there is, you can say, weak evidence out there from which we can draw some conclusions. So if you look at the EAU guidelines, here, there is a recommendation to use intermittent catheterization where possible, and it says what type of catheter use and instruct the patient on the technique, but it, if I might say, shies away from making a positive or a negative comment on the reusable catheters. If you look at the latest ICI incontinence guidelines, again, they are quite a detailed recommendation about the intermittent catheterization, that when it should be offered, who it should be offered, what type of catheter should be used. But again, it does not go on to elaborate whether one should or should not use reusable catheters. AUA guidelines, more or less the same. They acknowledge that catheter-associated UTIs are there, but provide no recommendation on the reusable catheters, or the state that hydrophilic catheters may be used in preference to standard urinary catheters. But when we look at the nursing guidelines, be it from the Society of Urological Nurses or the EAU, Association of Urological Nurses, there I think, if I might say, they stick their neck out and say that a new catheter should be used each time, and the EAU and nurses go on to say that this gold standard is a single-use catheter. And in their guidelines, they highlight the concerns about the cleaning efficiency and compliance. And one might argue that these are more robust because, as we know, that catheterization generally are taught and the troubleshooting by and large is done by the nurses. So they make a recommendation in favor of clean, intermittent, single-use catheters. On the other hand, the Canadian Urological Association, and there's quite a lot of evidence, we'll discuss a couple of papers from the Canada. They quite detailed outline the female catheters, the male ones. The language sometimes is vague, but as I have pointed out, they are the standout guidelines which make a recommendation specifically supporting that multi-use intermittent catheters can be used, which in a way you can say is in direct contradiction to other recommendations like EAUN guidelines, where they say that the single-use catheter is used. So the Canadian guidelines go on and say that the reuse of single catheters might not be the optimal, this is an optimal thing, but reusable catheter can also be used, and they stand alone on this position of multi-use catheters. So what about the published literatures? And you can have evidence both for and against, and here in this publication it shows that the single-use catheters and the reuse catheters, there's no difference between the two groups. But similarly, another study will show that if you use a single-use hydrophilic catheters, then they were preferred by most users. So we'll discuss the UTI incidence, which is linked to the quality of life, and then going on to the cost. And this again is from Canadian Urological Association, a very good kind of meta-analysis where you can see on the left side there the type of study, the single-use versus multiple-use catheters, the authors. By and large, if you look of these studies, it will say either the hydrophilic catheters are better or there's no significant difference. But most of the studies will say that there is a low risk of UTI with single-use catheters, barring the study from Kiddu, which shows that actually there's a low risk of UTI with multiple-use catheters. And one needs to go in quite a detailed analysis of the studies, and by and large, one finds out that overall the evidence is in favor of single-use catheters, which, where the UTI rate is less than multi-use catheters. What about the cleaning methods? Are there any instructions if you want to use the reusable catheters? Although there's a lot of recommendations that should be used antibacterial soap and water, alcohol sterilization, chlorhexidine, but neither, this is again from the Canadian Urology Association, but neither this nor the Cochrane review provide any statistically significant recommendation that one cleaning method is better than the other. What about the cost? And I think nowadays everything falls back to the cost, that the cost of single-use catheter is the main drawback. And that, if I might say, is the elephant in the room. If we take the cost out, then probably the single-use catheters are better. But I think from the perspective of the public payers, one needs to have a good value regarding the balancing of the complications to the quality of life gained with the cost. And there are a number of studies which have looked at the cost effectiveness and cost utility, and this is part of the health economics. So most of the cost comparison, it is very obvious, will show that the direct cost of the single-use catheter is much more than that of the reusable catheter. It's about 3 times. But once one factors in the complications such as the UTI, antibiotics, bacteremia, stricture, bladder stones, then the annual cost of the catheters is actually almost half of the single-use catheter compared to the reusable catheter. So there will be a 60% less long-term cost if the single-use catheters are used. So the conclusion is that single-use hydrophilic catheters have a low risk probably of the urinary tract infections. But like we always say that across the world, one needs to have a patient-centered approach, probably where, if possible and affordable, then hydrophilic catheters should be used as the first option. And this is a very nice actually study from Del Popolo. It is an editorial in one of the spinal cord series. They have nicely concluded that if you look at the EAU guidelines, aseptic intermittent catheterization is a valid substitution, which one can do even in the hospital setting. They have a low rate of the urinary tract infections, but no recommendation is made for the reusable catheters. On the other hand, if you look at the meta-analysis and a number of trials, they report no difference between the UTI rates. However, if you look at other studies, Hansen also was unable to demonstrate that the reusable catheters increase the UTI. So you can have your pick, and depending upon the evidence you want to show, there will be studies which show that there's a low rate of UTI or no difference between the reusable catheters. But again, and this is again from the Popolosi, a recent prospective trial has shown that the single-use catheters do improve the health-related quality of life. But I've put this in red, which might become discussion, that most of these trials are supported by the company which is producing the hydrophilic catheters. I think that what increasingly we like to do is to see what the patient wants, what they are using. I think this is a very nice table again from the same paper from Del Popolo, that if we ask the patients, is the risk of UTI management, sustainability, which is becoming more and more important nowadays, and the quality of life. And you can have pros and cons for the reusable catheters. There's a concern about hygiene. There's a good compliance. It's low cost, less impact on the environment. And especially if they are traveling, they don't have to carry around too many catheters. Versus the single use, they are more safe. They've got some storage problems. It's high cost and pollution. And when they are traveling, probably it becomes slightly difficult to carry a catheter supply for about 2 or 3 weeks. So we always say that we don't have randomized trials, and this is from Bertels. I think Bertels will correct me if I'm wrong. This is still ongoing trial, and this is where we would hopefully get the answer that if there's a non-inferiority of the reusable catheters, then it can have implications to increase patient choice, reducing the fear of running out of the catheters, less cost to the healthcare, and obviously less damaging to the environment. So very much looking forward to the results of the study, and I apologize, but I couldn't find that it is still out, but I think it will come in discussion. So in conclusion, Professor Bertel, that a single-use catheter probably decreases the rate of UTIs. It might improve the quality of life. Cost is an issue. One size does not fit all. Probably we need the long-term prospective trials. So in the context of developing countries where there's a pressure in the cost, probably the reusable catheters can be used till the time we can get the result from these randomized trials. Up until then, probably a patient-centered approach to consider hydrophilic catheters might be used as the first option. Thank you very much.
Thank you very much for your excellent talk, Professor Hamid. Next step, we will have the lecture from the next person. Julio, you're the next, or?
I am the last, I think.
Okay, it's Thomas, because I don't see it anymore. Thomas, you can start your presentation. Maybe you could also open the camera. And I want to remind everyone that it is possible to ask your questions on the Q&A or in the chat. And after the 3 presentations, we will answer all your questions. And there will be also some multiple choice questions asked, which you can answer. Give the floor to Thomas.
Thank you, Bertil. Ladies and gentlemen, it's a great honor actually for being here in this webinar, and thanks you all for the interest in neuro-urology. Especially urinary tract infections are an issue that we are faced day by day in neuro-urological patients. The situation that we currently have is what are the conflicts of interest? Rizwan already pointed out in these studies with catheterization, you always have to know who paid for the study. And what are my conflicts in this UTI context? In principle, there is no conflict of interest, but be aware, I'm involved in several of the trials with bacteriophages. And this may be relevant when you will go through this lecture. You will learn what it is going into that perspective in the future. Urinary tract infections are one of the biggest challenges that we are faced, not only in neuro-urology, but also in medicine in general. UTIs, how can we treat our patients? The question is first, how to diagnose a patient with a urinary tract infection. With the non-urological population, this is very easy and straightforward. But think about what is the definition of a urinary tract infection in a patient with an underlying neurological disease. And from the EAU guideline group, we exactly looked into this definition question. Very recently, it was published, this definition paper in European Urology Focus. And ladies and gentlemen, the big problem that we have in neurourology is that there is no generally accepted UTI definition in neurourological patients. And consequently, this is something what we have to bring forward. This is essential. Otherwise, we cannot compare the different studies. And it is very challenging then, even more challenging than to come to a conclusion what it is really helping in our group of patients and what it is not. It means a generally accepted UTI definition from neurourological patients is urgently needed. We are working on that with the EAU guideline approach on a Delphi consensus, and I strongly hope that we arrive to that level where we can bring it forward to a generally accepted definition. But, ladies and gentlemen, the patients are not waiting up on the definition is out. We have this patient with UTI, and how are we treating in neurourology this type of patients? What is in our guidelines? In the guidelines, what we have is strong recommendation for 4 essential points in daily clinical practice. First, do not screen for or do not treat asymptomatic bacteriuria in patients with neuro-urological disorders. This recommendation is derived from a level of evidence 1A. This is the highest evidence that we really have in this topic. The second one, it is that we should avoid the use of long-term antibiotics for recurrent urinary tract infections in patients with underlying neurological disease. This is derived from a level of evidence 2A. And the third one, in patients with recurrent UTIs, optimize the treatment of neurourological symptoms and remove, for instance, foreign bodies such as stones, indwelling catheters from the urinary tract. It means when you have a recurrent UTI in this group of patients, you have to make sure that the lower urinary tract is managed appropriately. Derived level of evidence, grade 3. And here, the last but not least, there is no optimal prophylactic measure available for our group of patients. Therefore, you have to individualize UTI prophylaxis in this group of patients. And also this is derived from a level of evidence 3. How we are currently treating our patients. It is the situation that you are faced also day by day, antibiotics, and again antibiotics. Currently, there's no other generally accepted treatment than the antibiotic treatment in the case that it is indicated. please avoid to treat patients with asymptomatic bacteriuria. But what do we have as alternatives? For instance, bladder washing or bladder instillation or bladder irrigation. What do we have on our hands is just to wash the bladder with tap water, to wash the bladder with other solutions like saline, like citric acid, like antibiotics. But the evidence, ladies and gentlemen, is still not there for all these alternative treatment options. Honestly, I have to say, we are also treating patients with bladder washing quite efficiently. It means in a way that you can avoid an antibiotic treatment. It is a possibility, but please be aware, this is not evidence. It is more evidence-based medicine. And the appropriately powered and designed RCTs are not yet there. What other options do we have? I just mentioned at the very beginning my conflict of interest. It is going back to the future. What does it mean going back to the future? It is so that Felix Darrell and Frederick Dwart, more than 100 years ago, they actually detected bacteriophages. They discovered bacteriophages. And a bacteriophage means it is a bacteria eater. The bacteriophage is a virus, and the virus is a natural predator of bacteria. This bacteriophage attach to the bacteria, inject the genome into the bacteria, then it induces a self-amplifying cycle in the bacteria, and finally, they are produced many little phages, and these phages cause a lysis of the bacteria. The bacteria is killed, and a lot of little phages are released. They can attack other bacteria again. It means this is something what is abundant. It is everywhere available. This is something what it is not new. It is an old way. And in the ex-Soviet countries, it is still a therapeutic option that it is used for any type of bacterial infections. And in this way, faced day by day with these patients with a recurrent UTI, what did we do? We looked into what it is available in the world, especially in Georgia. It is the best established and well-known Institute of Bacteriophages in Tbilisi, in Georgia. And there is also a cocktail commercially available, the Pyophage bacteriophage cocktail. And together with our Georgian colleagues, actually, in a joint venture between Switzerland and Georgia, we designed the first randomized control trial worldwide using bacteriophages against urinary tract infections. The results have been published very recently, but be aware, these are non-neurological patients. What did we do into this trial? It was a 3-arm trial. On one arm, we had a bacteriophage treatment, a Pyophage solution commercially available in the pharmacy in Georgia. It was instilled in the bladder using the suprapubic catheter 2 times per 24 hours for 7 days. And an identical solution was a sterile bacteriology solution as in the placebo arm, also instilled through the suprapubic tube. And the 3rd arm was a standard of care. Obviously, this was not double-blind. The 3rd arm was an open treatment was standard of care antibiotics. Antibiotics according to the antibiotic sensitivity pattern. Here, the consult flowchart of this trial. What it is important, we assessed more than 470 patients. Finally, we randomized more than 110 patients. And in this 3-arm trial, we looked for superiority, but we also looked for non-inferiority. And what was the outcome? The outcome was completely unexpected. The outcome was that we had similar efficacy and also similar safety in all of these 3 arms, ladies and gentlemen. It means there was no non-inferiority of bacteriophages against standard of care, against antibiotics. But it was also not superiority of bacteriophages against placebo. It means whatever you do in this RCT from a statistical perspective, it was the same. In this way, we just were thinking this has to be looked into in more details. What can be improved to get better results? Because it's always in such a trial, you can look it in 2 different ways. Is it positive or is it negative? For instance, having the same efficacy as antibiotics without the potential to get antibiotic resistance would be a positive sign. But obviously, if you can achieve this also with a placebo solution, then you have to think about blood washing. Is this an option? And in this way, what we did, we looked into the details. We used wild-type phages. It is a question how we can improve these wild-type phages. And with our engineers at the ETH in Zurich, we were able that they can genetically modify the phages in such a way that they're very specific, that we don't need a cocktail anymore, that they can kill specifically the bacteria that is your target. And here there are studies going on. It is the cautifage trial. It means this is a study where we look into a different type of population, where we find out whether patients with catheter-associated urinary tract infection can be treated with bacteriophages. Another one is that we don't only kill the bacteria, it is immunophage, that we also like to modulate the local immune system in a way what we are usually doing when we are treating with BCG, the carcinoma in situ in onco-urology. This is a way how to modify the phages. And last but not least is the mTORus study. mTORus is when we kill the bacteria and then bringing into a healthy microbiome with a microbiome transplant into the bladder in a similar way as they already do with fecal transplantation. You see, ladies and gentlemen, it is an exciting way, but there are still many, many questions. But there is light at the end of the tunnel. And at the end of the tunnel, there is waiting a little friend, our bacteriophage, with the potential to revolutionize the treatment of UTI. Thank you.
Thank you very much, Thomas, for your excellent lecture. And then we go to the last speaker, Professor De Popolo, and he will talk about lower urinary tract symptoms in neurogenic bladder, specifically Parkinson patients. And we're just waiting for seeing your presentation. Julio, we don't see it yet.
It is still our little friend, Julio.
Very good. In the meantime, we already have 3 questions. I encourage you to send in your questions, and we can answer them later on. Here it is. You must unmute your microphone. Julio, we don't hear you. Julio, you're still.
Yeah.
Now
Can you listen me? Can you listen
yes,
me now?
Excellent. Thank you.
Okay. Thank you. Sorry for delay. So I have this nice topic, and LUTS in the Parkinson patient. And I have to speak about botulinum toxin at TURP. It means that are really opposite. I mean, it's like if you like the swimmer time, or the summertime, or the winter time. It depends if you want to swim or if you want to ski. In this case, botulinum toxin, you know, is just to improve the feeling phase, and the TURP is just to improve the body phase. So are really different. Here are my disclosure. And as you can see, we have a prevalence of Parkinson's disease all over the world of about 6 million. And in Europe, you have a prevalence between 8 and 130 for 100,000 population. And if you look at this graph, the range of the age that are more and more Parkinson is between 60 and 90 years old, and male are more than female with Parkinson. And at the same time, is in the same range of age between 60 and 90 that there is more disability for this patient. So you have also to take consideration not only low urinary tract dysfunction, but all disability that these people can present. So if you look at this nice review, the first thing is just to have clear that Parkinson's disease is much different from multiple system atrophy. And as you can see in this figure, the Parkinson's disease is something that impact on dopaminergic system. The MSA is something that impacts more nervous system, the striatum, cerebellum, and also on of center. So is a different outcome. For this reason, in urodynamic investigation, usually you find in a PD patient the truser activity, mild BoNT-A, impaired urethral relaxation, and some delayed striated sphincter relaxation. Instead of in MSA, we can find the truser activity, but at the same time, uninhibited urethral sphincter relaxation during feeling, but bladder neck opening, and also you have a reduction of bladder contraction. And from therapy point of view, the dopaminergic drug therapy is effective in Parkinson's disease, but not in MSA. And TURP prostatectomy seems to be effective in this review in a PD patient, but not in MSA. So you have excitatory effect on micturition in PD patient that leading to the dopamine D1 receptor activation, which results in reduced activation of inhibitory GABAergic neurons in the striatum. So it means that we have a double effect, excitatory and inhibitory at the same time. And if you look at the EAU guideline on neuro-urology, we report that the urinary symptoms affect about 50% at onset, and the main symptoms are urgency, nocturia, and patients that present urinary symptoms just at the beginning, they have worse disease progression. And the other point that we underline is that in impaired detrusor contractility, and high post-void residual is more common at the beginning in MSA patient. So, I don't know why. So, also from last version of ICI, we have some evidence that Parkinson's disease and low urinary tract symptoms are associated with the generation of dopaminergic neurotransmission. And the most common low urinary tract dysfunction are detrusor overactivity during storage and impaired detrusor contractility during voiding. The effect of levodopa on LUTS in PD patients remain to be fully elucidated. But we are also to remember that Parkinson patients that have also associated increased nocturia, they usually have a severity of disease. And also you have also to remember that in this Parkinson group, sometimes they have also a dementia complex. So they can have some cognitive problem that we must take in consideration when we decide a specific treatment. EU guideline advise and give a strong recommendation to perform urodynamic, also non-invasive testing such as uroflowmetry, and if it's possible, also use a video urodynamic. Anyway, in the Parkinsonism, can result in DO, can result in BO, in the synergic voiding. So we have DO, DU, detrusor underactivity, with or without urethral sphincter pseudodysynergia that are commonly found in male patients with Parkinson's disease. So we have a really hard situation because you have all in one patient. All dysfunction can be present just in one patient. So you have to manage the ODU and also anatomical obstruction or functional obstruction. Botulinum toxin is indicated in a patient with DO, but in this patient, maybe there is also association with DU. Instead of, on the other hand, we have a TURP that is indicated in patients with anatomical obstruction, but we have also to take in consideration if there is a functional obstruction or if high residual urine is due to detrusor underactivity. So if you look at ICI guideline that are a general neurological guideline, yes, Parkinson is mentioned here, but if you look at therapy, maybe the only one is antimuscarinics that I can find here. Intermittent catheterisation, I think, is not the best indication for this kind of patient. And if you look also in specialized management, again, we don't find any indication for TURP, just indication for BoNT-A, and at the same time, we don't find the indication for alpha antagonists that usually maybe they can use just at the beginning of our treatment if they have high residual urine. And so if you look also at this algorithm by ICI, by ICS, yes, they just mention antimuscarinics, but not other type of treatment. So I like more this review that was just in 2022, and the others first analyze all factors that influence storage symptom and voiding symptom. Then after the first approach, they recommended to perform urodynamic study. And if you detect the detrusor underactivity or bladder outlet obstruction, is a contraindication to use botulinum toxin. Instead of if we detect that there is detrusor overactivity, but with a low post-void residual urine, now there can be an indication for botulinum toxin, intradetrusorial botulinum toxin. But For example, in this case, that is a Parkinson patient using alpha blocker, you see there is NDO, there is a problem also of no relaxing sphincter, distal sphincter, and he has also not very nice uroflowmetry here. So in this case, we can use botulinum tox or not? This is the big problem to solve. Anyway, about botulinum toxin, you had the first publication by Giannantoni and Anderson, and they use just 100 or 200 units of botulinum toxin. And in this review, they report this study with a low dose of 100, where they report a good result, but just a decrease of incontinence of 50%. And was a similar result with 100 and with 200. But anyway, most of these patients were just female patients, and no male patient with BO. There is another study, but I think this is with Botulinum with 500 units, and is only in female patients. So the conclusion of this systematic review is that, okay, it can work with 100 or 200 units, but you have to take in account that the residual urine can increase, and maybe they can have the necessity to use intermittent catheterization. In this study, they just out of a total of 356 patients treated 26 Parkinson disease patients, and for analysis are available only 24. But if you look at the table, only 17 were male patients, and they report success only in 12 patients out of a total of 17 male patients. So the conclusion is that intradermal injection can give a good success rate for incontinence, but you can have also de novo incontinence, and also there is that some patients, here is reported about 12%, need intermittent catheterization for urinary retention. So the final conclusion is that higher pre-injection post-voidal residual urine and male sex decrease the probability of symptomatic improvement. And this is important because you have also a large number of patients studied in this report. So in case of bladder outer obstruction, we can use alpha blocker as a first aid, or maybe there is just one paper using botulinum toxin in the sphincter, but you have really limited data to give recommendation to use botulinum toxin in Parkinson patient in the sphincter. And if we go back to this study and to this algorithm, if you have a patient with a high residual urine, more than 200, here you can consider to use alpha blocker or to do a TURP. But on my mind, it's also important to demonstrate that they have a BPO, a bladder prostate obstruction. Otherwise, it's not usable to do TURP. So here what to say about TURP that is indicating male patient with a refractory LUTS due to benign prostatic obstruction. But we have to consider also the abnormal sphincter function that can lead the patient to be incontinent or to a de novo incontinence. And also you can take bladder neck resection in case that there is obstruction of the sclerotic ring in the bladder neck. So if you look at data, we have two main papers, one by Roth and is involved also Thomas Geisler, and another by Staskin. And based on these two work, you can say that the TURP is no longer contraindicated in PD patient, especially after retention. But if you look into detail in the Staskin paper, they increased post-TURP incontinence from 17% to 28% post-op. And they underline that is very important if patient with pre-operative poor voluntary sphincter control, because they are more likely to experience post-op incontinence. Instead of in the Roth paper, they studied 23 patients, and 10 of them with pre-op urinary incontinence had improvement and resolution after TURP. So they do not report de novo urinary incontinence after TURP at 3 years. So the conclusion is that Parkinson is not a contraindication to TURP, provided that BPO is proven. And there is a review that in this review, Bertie Bloch and his group reported just the data that we saw before, with de novo urinary incontinence from 0 to 20%. And so they recommend the preoperative urodynamic to proven BO. And also they advise to distinguish a functional BO from an anatomic BO. And this is not always very simple. There is another abstract presented at meeting by Peyronet. In this case, they treated 42 patients, and they report a good outcome, but they underline that there is high rates of patients with worsened symptom post-op, about 21%, and also 11.5% with de novo incontinence. So a good selection is needed, and also an appropriate counseling to the population before this kind of treatment. So I think that in this algorithm is the most complete. And here you will see that you can just start with a behavioral therapy if they have a normal uroflowmetry without OAB, no post-voiding residual. But if they have OAB, they is subject to and no post-voidal residual with a normal uroflowmetry, they suggest to use first antimuscarinic or botulinum toxin, and also to take in consideration some kind of neuromodulation. Instead of, if you have OAB with a large post-voiding residual urine, the treatment is just to use alpha antagonist or to take in consideration TURP, but also combined with the antimuscarinic if OAB symptoms are present. Instead of, in case of large high post-void residual urine without OAB, they just give indication for alpha blocker or cholinomimetics. I don't like cholinomimetics, and so I think that in this case maybe you have to take in consideration to perform a TURP. So TURP, yes, if anatomical obstruction is documented, but you have to exclude that if the high residual urine is due to underactive bladder or to pseudo-dysynergia. So in conclusion, the botulinum toxin male patient with PD and with NDO without high post-voiding residual urine or BPO as high success rate and they are but limited data. So counseling concerning the risk of urinary retention and need of intermittent catheterization should be done to the patient. And about TURP is indicated only in PD patients with urodynamically proven BPO, and the counseling concerning the risk of post-op incontinence should be done. But also combined therapy in select cases, TURP and BoNT-A or antimuscarinic should be considered. And last but not least, remember that the patient must be able to reach the toilet, and this is not always possible in this kind of patient. Thank you for your kind attention.
Thank you very much, Julio, for your excellent presentation. And the next step is that we go into the questions which have been sent in the Q&A. I will begin with the first remark. It's from Jane Mylink. Reusable catheters may cause more infections requiring more treatments and may ultimately be not cheaper. You would like to comment on this, Rizwan?
Yes, but Jane, thank you very much. I completely agree. And like I presented, if you look at the data, probably the only thing which comes out is for majority of the studies, it shows that the single-use catheter have low UTI rate than the reusable catheter. And then, like I presented in that meta-analysis, that when you translate that into managing the complications with infections, bacteremia, stones, strictures, and just it appears that the single-use catheters come out on top.
Thank you very much. Then the first real question is also for you, Rizwan, from Bernardo Teixeira. Do you think the route of CIC, for example, Mitrofanov versus urethra, for example, makes a difference when choosing between reusable and single-use catheters?
Well, the honest answer is I don't think so that there is anybody knows. I'm not aware of any study which has been done looking at the two different things. So the scientific answer is no, we do not know. And I think probably the rate would be the same, that the comparison between the urethral single-use and reusable catheter, that can be translated into the Mitrofanov. So between the two, no, I don't think so there's any evidence.
Thank you very much. Then a couple of questions for Thomas from Josef Marinchak. What non-antibiotic prophylaxis prevention do you recommend for neuro-urological patients with recurrent urinary tract infections?
Yeah, thanks, Bertil. The way is a bit when you look into the evidence only, then you have to say we don't have the evidence for any of this preventive measure. But obviously, as it is also marked in the guidelines, is that we have to individualize the treatment or the prophylaxis. And in this way, the most and relevant point here is to exclude that you can optimize the lower urinary tract function. It means look into, do the proper diagnostic workup if there are no stones, if the lower urinary tract function is adequately controlled, then it's a try and error situation. And in this way, the evidence is not there. It is all, in principle, an off-label part in the neuro-urological population, and try and use what your patients helps most. But don't think that it is a general rule. It is only individualized prevention and prophylaxis.
Thank you very much, Thomas. And the next question, maybe it can be combined with the other one. Interesting, this remark is from Danny Darlington. Interesting topic. Are there any exclusion criteria for the bacteriophage treatment? And the other question from Bernardo Teixeira was, what was the main outcome of the bacteriophage RCT, symptom resolution or sterile urine? Any differences in the long-term symptoms between the groups?
Yeah, it is important to understand the bacteriophage RCT was on non-urological patients. And in this way, it is so that for a bacteriophage treatment, you have to bring your patients into a trial. I wouldn't treat the patient outside of a trial, because then we cannot bring our knowledge forward. And bringing this to the question, what was the primary outcome in this RCT? The primary outcome was actually the clearance of the urine. It means it was a microbiological outcome, and the secondary outcome were the symptoms. But the way is, the study was powered for the primary outcome, as all of these RCTs are. Here, it was per hazard, so that if you have a success in clearance from the myological perspective, then it was also that the symptoms disappeared. But powered for microbiology and not for both.
Thank you very much for this, in my view, clear answer. The next question is also for Thomas, from Azizbek Shomarufov. Dear Professor Kessler, what do you think about treatment of neuro-urological patients with recurrent UTI with Urovaxon?
In principle, it's going back to the first question. There is no proven high-level evidence on that. But if you have done all what you can, and in the case that all these recurrent UTIs are caused by E. coli, this is important. It doesn't help for Klebsiella or Pseudomonas or Proteus or anything else, then you can try and error, but be aware it is eminence and not evidence-based medicine here.
Thank you very much. Then the last three questions are for Julio. The first one is from someone who is anonymous. Can patients be obstructed due to impaired non-relaxation of the urethral sphincter and not due to BPH?
Thank you for the question. And yes, in case of no relaxation of the distal sphincter, they can be obstructed, but usually they have bradykinesia. It means that after time it relaxes, so they present a longer time of voiding, but usually they void all with a low residual urine. If you find this situation with a pseudodysynergia and you have higher residual urine, you have to suspect or if it is combined with underactive detrusor or with also BPH.
Thank you very much, Julio. And then the next question from Bernardo Teixeira. Would you not use Botox if the patient had low-grade obstruction? From what grade of obstruction, for example, in the Schaefer nomogram, would you counsel against Botox for overactivity in patients with Parkinson's?
In my clinical practice, I don't use botulinum toxin in Parkinson's disease. I use only botulinum toxin in Parkinson's patient with indwelling catheter, and they maybe can have incontinence pericatheter, and there it works very well. But anyway, you have seen there are data that you can use that. And if you have to use that, you have first of all to demonstrate DO and to exclude that there is underactive detrusor during the voiding phase. But if you look at obstruction, you can use also the Schaefer nomogram. I think that class 2, no more than class 2. Thank you.
Okay, and then again for Julio, the last question, which has been asked online from Nestor Katz. Is there any role of tibial nerve stimulation or other type of neuromodulation in Parkinson's disease patients?
In Parkinson disease has a great role at the moment, the deep brain stimulation. And it is demonstrated that when it's on the deep brain stimulation, the ORB is better, it improves. Anyway, there could be a role. And in my mind, because we have no data, in this kind of patient, I prefer the tibial nerve stimulation instead of neuromodulation that is more invasive. I think that maybe after a trial with the tibial nerve stimulation, if you have a good result, but they lose the result during time, after you can take in account to perform sacral neuromodulation. But this is my opinion. We have not a lot of data about this aspect in PD patient. I think that Bertil is also very expert in this field.
We all are, I think. Thank you very much. It brings us to the conclusion of the webinar, the AAU webinar. You will receive in 24 hours a link for the multiple choice questions, which you have to fill in to earn your CME credit. I want to thank all the participants, Professor De Popolo, Professor Rizwan Hamid, and Professor Thomas Kessler for their participation. I think it was a very good and very fruitful session. And we all see you the next time. Thank you, all the participants. There were at the high level 115 participants active. Thank you very much for your participation. And hopefully we see all you the next time next year. Thank you very much.
Thank you very much, everyone.
Thank you. Thank you.
Thank you. Bye-bye.
Bye-bye.